the moderators for the invitation and Professor Carraro. The topic of my speech is the ultrasound imaging of fascia. And we changed the terminology in the last years about the evaluation. È questo qua? Ma per scorrere con le...
Sì, guarda, due pulsanti, prova. Guarda, sopra o sotto, prova l'altro. Va.
Con quello sopra?
Quello sotto, prova.
Okay. And the terminology about the ultrasound imaging change in ultrasound examination because we can put together the clinical examination in the daily practice, but also the use of the probe to highlight the differences among our tissues. And among these tissues, there is an increase of publication also about the fascial layers, but in the idea of the ultrasound examination is not the Padua fashion design or only the topic of our institute, is an evidence in the literature. And we have an increase of publication in the last 50 years about this topic. So we have different notes about this VOS viewer software. We can see that we have research about the different type of fascia, but also among the different genders, the different age of our patients. And the main question at the end of this literature are only two. What are we seeing, and is it possible to see the same structure? Because after this, we have reliable protocols and reliable information among the different measurements. So for this, we decided as first journal to publish this paper that put together two images, the histological image, an Adams-Mallory staining, and also an ultrasound image. And we can put together, with the help of the scheme, that the image, the ultrasound image, is the same of the histology. Number one, number two are the epidermis and the dermis. But the Cinderella of the ultrasound imaging, the subcutaneous tissue, really is composed by the superficial fascia, number 4, that is an hyperechoic line inside of the subcutaneous tissue, and number 3 is the superficial adipose tissue. Number 5 is the deep adipose tissue. Our deep muscular fascia, that is the best known structure among the fascial layers, is the number 6. Our muscle is number 7. So we can conclude ultrasound imaging of fascial layer, you see only what you know. We must know this structure to assess very well these structures. And for this, we published different papers, but also to assess the reliability of our measurements. And we start with the abdominal fascia. This is, for me, I love this paper because it's the first paper that put our lens on the reliability of these measurements. And it was also cited by the European Federation for the Ultrasonography. And this is the first paper that evaluated this type of reliability. But it's obvious that we have the same organization with differences in the thigh, in the leg, in the abdominal wall, in the back, between the histological images. And we have also differences between the anterior, the posterior, the lateral, the medial compartment, but the images are the same. We must translate this histology, this anatomy in the ultrasound imaging. And is it possible? Is it possible also to calculate the difference between the medial and the lateral part, between the anterior and the posterior part? And it is present obviously in the deep muscular fascia, but also in the superficial fascia. It is possible for the brachial fascia, but we must use the same protocols to have a multi-center studies. And this is our proposed protocol about this type of evaluation for the brachial. Here is evident that we have a difference between the anterior and the posterior compartment, but also for example, for the antebrachial fascia, the deep muscular fascia of the forearm, this difference is not present. So we have variation in the various topographical regions. And also here, for us, it was evident that these data are reliable. We must reproduce our protocol. This is possible also for the head, for the neck. We evaluated the temporalis fascia, but also the fascia of the scom, the fascia of the masseter. And also here the reliability, it was between the good and the optimal value. But also we can correlate this type of evaluation, the thickness, with our daily practice, with the score that we use every day in our rehabilitative setting. So we correlated the evaluation of the leg, of the crural fascia in the different compartments, and also the epimysial fascia in a particular point, the level 2 above the anterior, the tibialis anterior muscle, and there was a correlation, a negative correlation between the reduce of the ROM and the increase of the thickness of this fascia. So there is a sort of sticky state of this fascia that maintain the possibility to explain this type of movement. And also here we had a good intra-reader reliability. But why this sort of shell about the thickness? Because the thickness in our translation mentality is really important to infiltrate our fascia, but also for our pain management. And it was evident in the minimally invasive cardiac surgery, in which a good knowledge of this thickness, this layer, can determine a good performance to inject and to use a fascial regional anesthesia that is compared with the general anesthesia. And the data were real evident. We have a reduction in the CPOT score, a score for the pain, but also in the total opioids that we used, in the additional analgesia, in the orotracheal intubation intensive care unit time. This is an information that seems not important, but is really important in the post-surgery of our patient, in the quality of life after the surgery. And for this, the knowledge about the fascia is important. And is important also for other collateral symptomatology after these drugs. But we can use this type of thickness also to use the fascial anesthesia for particular situation. For example, in the elderly women, during breast surgery. But also here is important to know this type of thickness between, for example, the pectoralis major and the pectoralis minor, but also between the serratus anterior and pectoralis minor. This is fascial layers. The other structure that we don't know very well in the ultrasound examination is the superficial fascia. I think that the ultrasound histological images of these structures speaking louder than words, because in this image is really evident that we have this hyperechoic line inside of the subcutaneous tissue. It's the same in a specimen, but is also a same in the histological image. But also here is important to maintain a good protocol during our evaluation. It's important to maintain perpendicular our probe during the evaluation. So before to say it's not possible to evaluate the fascia, it's important to know very well these structures. It is important to know very well our ultrasound machine. And also here it was evident that we have a difference between the thickness in the anterior and the posterior compartment, because the superficial fascia, but the supercutaneous tissue is not the same in the anterior and the posterior for the organization also of the adipose tissue in this type of structures. And it was also evident not only in the arm, but also in the forearm. And also here, our measurements were reliable. For this, we decided, yes, we are the group that know very well this ultrasound imaging, but is it possible also for a beginner, for a dummies, to start to evaluate this type of structures in a good manner? And it was possible, because we compare the evaluation of one sonographer with an important experience in the ultrasound imaging and a radiologist at the first year of the residence period. And also here it was evident that yes, obviously, we are some fascia that are not possible to evaluate in the best way at the first time. We must study, but it's the same for everything, for every structure. It's the same for the muscle. We cannot start with the evaluation of the rectus femoris, and it's the same, for example, the evaluation of the subscapularis tendon. We have a difference in the curve learning of this type of structure. And it was evident also this in the superficial fascia, in which we have sub-millimeter structures, sub-millimeter thickness. And sometimes we have a wave behavior of this tissue. But when is there superficial fascia dysfunctional? Because it's important to evaluate this thickness. Because sometimes we know that superficial fascia is more innervated. Sometimes with the use also of the tool of the sonopalpation, we can stretch the superficial fascia and evocate the symptomatology of our patient. But also with a static image, we can highlight a sort of steady state, as in the figure C, between the superficial fascia and the deep fascia, in which we have an alteration of the echogenicity and in which we have an alteration of the histology. So an important deposition of collagen and hyaluronan and alteration of disorganization. It was evident between the left and the right of these images that we have an image in which we have an increase of the thickness. In the translation of our knowledge of the gray scale level is a disorganization of this structure. There isn't an harmony in the wave of this structure. And it was evident for us also in other type of scar. But I don't want to bore you with the different ubiquitous relationship that has the fascia. But it's the same also with the nerve, because we have a continuity with the nerves, and in which this continuity can alter the gliding of this structure. We have a gliding inside of the fascia, but we have also a gliding in relationship to the other structures. In particular with the nerve, we have a longitudinal gliding, but also a transversal movement, a transversal displacement. And we evaluate this in the carpal tunnel, but also in the forearm, in the middle of the forearm. And with the use of the histology, also here we can highlight, shed light in this continuity between the paraneural sheath, but also the epimism. So an alteration from the muscle can, with a cascade, determine an alteration of the nerve, and maybe also in the reverse direction. So for this, with our colleague Chicken Fund, we decided to evaluate the echogenicity. The echogenicity in the ultrasound imaging is the mirror of the alteration in our structure. What is the alteration in the extracellular matrix near and close our nerve? And in the left of these images, we have an increase of the echogenicity because we have an increase of the deposition of collagen and an alteration in the aggregates of the hyaluronan. And it was evident with the use of the same setting in our evaluation at the carpal tunnel and in the forearm. We used for the displacement a type of algorithm with the centroid system, and this is the summary. We have an increase of the echogenicity, so we have an alteration of our continuity, our fascial layers, and a decrease of the displacement of these patients. But also here is reliable to evaluate this alteration. So we can finish the nerves never walk alone, are together the same unit. Maybe we can translate from muscular unit to myofascial unit, and why not in the future we can talk about fascial entrapment neuropathy. I think that this is the last, the take-home message. We must change the mentality. Yes, there is the muscle, but there is also the surrounding structures near the muscle. And is similar to the medicine. We must know also around, not only the single problem. For this, you see only what you know. We must know a lot about the fascia. Thank you, Professor Carlastecco, to carry on these studies, and our department in the Institute of Human Anatomy.